Good morning, afternoon or evening. Glenn Phipps here. The presentation you're listening to is on type 2 diabetes. A little bit of background information. We're looking at the case study on Patricia, a 53-year-old female, fasting blood glucose 11.5 millimoles. Her doctors recommended metformin and she undergoes a lifestyle intervention. We'll be looking at the pathophysiology of diabetes, relevance of HbA1c, macrovascular complications, metformin, and lifestyle interventions in this order. To give a little context, it's predicted by the year 2030, more than 366 million people worldwide will have diabetes. While this figure is quite daunting, with the ageing population and growing obesity epidemic, predictions may well exceed these. The rate of diabetes-related mortality has risen from 5.2 to 6.8% between 2000 and 2010. It's a leading cause of blindness in 20 to 74-year-olds. And neuropathy occurs in 60 to 70%, with 60% of non-traumatic amputations occurring as a result. Heart disease is 2 to 4 times higher. Pathophysiology of diabetes is thought to be a direct extension of glucose control. The glucose system is highly homeostatic, whereby a plasma glucose concentration represents a balance between entry of glucose into or exiting the circulation. Type 2 diabetes is the clinical manifestation of long-term metabolic abnormalities involving multiple organs and hormonal pathways that impair the body's ability to maintain glucose homeostasis. The metabolic abnormalities that lead to type 2 diabetes involve insulin resistance, the deranged secretion of insulin by pancreatic beta cells, and increased glucose production by the liver, whereby both genetic and environmental elements are seen to affect beta cell function and tissue insulin sensitivity. Type 2 diabetes is a bipolar disease characterized by a defect in both insulin secretion and insulin action, whose complex interaction leads to a progressive increase of plasma glucose levels. Insulin resistance is generally taken to mean a reduced ability of insulin to stimulate glucose transport and utilization. As the body reduces its response to insulin stimuli, the cells uptake less glucose and blood glucose levels are elevated. Insulin resistance was first used to describe patients who developed antibodies directed to doses of insulin that were given to target hyperglycemia. Currently, the term refers to a state in which a given concentration of insulin produces a less than biological effect. The actual mechanisms of insulin resistance are still not well understood, and there's a huge amount of literature on the subject. A number of factors are involved in the pathogenesis, which we'll explore a little here. Firstly, there's a number of endocrine hormones which have been shown to be increased in diabetic patients that are suggested to play a role in insulin resistance and may regulate glucose homeostasis and carbohydrate metabolism. These include ghrelin, leptin, adiponectin, and retinol binding protein 4. An altered balance of the parasympathetic and sympathetic nervous activity, mainly explained by an attenuated parasympathetic activity, might contribute to the development of insulin resistance and type 2 diabetes. It's also suggested sympathetic overactivity is directly correlated to insulin resistance and cardiovascular events. The impairing effect of the autonomic system is multifactorial, with pathological alterations of insulin, leptin, ghrelin, ghalanin, nitric oxide, endorphins, and neuropeptide Y playing a role. Norepinephrine itself is seen to raise fasting glucose levels via transiently increasing basal hepatic glucose output. The microbiota influences energy harvest, energy metabolism, and the development of systemic inflammation. Gut microbiota has been shown to play a significant role in the development of obesity, obesity-associated inflammation, and insulin resistance. Gut microbiota affects metabolism by increased energy extraction, modulated immune system, and altered insulin sensitivity, and other factors such as altered fatty acid metabolism. Whether changes in microbiota are the cause or effect of obesity are open to debate, and there's some debate as to the impact of diet on the relative microbiota. PPARs regulate adipocyte metabolism and are related to the development of obesity. They increase the decomposition of triglycerides in adipose tissue and skeletal muscle and inhibit glucose secretion. Vitamin D deficiency results in the development of insulin resistance. Vitamin D deficiency is thought to predispose individuals to glucose intolerance and insulin resistance, and reduce insulin secretion, as vitamin D not only improves insulin sensitivity of target cells, but also improves beta cell function. Reactive oxygen species are thought to be key integrating mediators in the development of insulin resistance. They can suppress the insulin response and contribute to the development of insulin resistance. This is proposed to occur via a number of mechanisms as noted here related to mitochondrial function, endoplasmic reticulum stress, and inflammation. Diet's thought to be a risk factor in this regard, particularly diets that are high in carbs and fat. The overworked hypothesis suggests that type 2 diabetes is suggested to occur following years of glucose intolerance or impaired glucose tolerance, whereby years of hyperinsulinemia result in decrease in beta cell insulin secretion ability. On the contrary, it's been suggested that insulin resistance alone is insufficient to cause glucose intolerance, and that a defect in insulin secretion must be superimposed. There's no consensus at this stage which comes first. A number of risk factors exist as shown here, such as genetic predisposition, obesity, inactivity, aging, medications, polycystic ovary syndrome, partial lipodystrophy, and diet. Obviously, given the discussion so far, obesity is seen as a major risk factor. However, it's suggested that this only relates to those with a genetic disposition. What we can see here is the diagnostic criteria taken from Diabetes Australia Guide to General Practice. At this stage, inclusion of HbA1c levels are not included as recommended by the American Diabetes Association, but it's expected to be included in the future for reasons that we'll look at now. HbA1c refers to glycosylated hemoglobin. The rate at which glucose enters a red blood cell is not insulin dependent and relies on blood glucose levels. HbA1c is considered an index of mean plasma glucose over the preceding weeks and months. Fasting glucose levels are thought to significantly underestimate HbA1c levels and the subsequent risks. A 1% rise in HbA1c is associated with a 37% increase in microvascular disease and has been shown to be an independent predictor of healthcare costs. The average HbA1c has been shown to be around 8% 1 year after diagnosis, indicating that testing HbA1c levels may be useful in an earlier diagnosis. HbA1c levels are strongly associated with cardiovascular events and suggested to be a strong criteria for screening combined diabetes and cardiovascular risk. It's been suggested that the diagnostic toll for diabetes should include the risk of macrovascular disease. While oral glucose tolerance test is strongly associated with microvascular risk, it does not account for the macrovascular complications. It's been suggested that the current diagnostic criteria of glucose itself is also actually too low. A small amount of patients might develop microvascular complications when HbA1c levels are between 6 and 7%, with studies showing no development when it's below 6. It's suggested that some patients currently diagnosed as diabetic may actually have normal HbA1c levels, suggesting they have been wrongly diagnosed. The degree of hyperglycemia is associated with an increased risk of macrovascular disease, with HbA1c levels very strongly associated with the risk 2 to 3 times higher macrovascular complications at levels over 6%. Obviously, our case study fits into this category. The risk of macrovascular disease is 2 to 4 times higher in diabetes patients, with 50 to 75% of all type 2 diabetes patients dying of a macrovascular problem. Type 2 diabetes patients are 2 to 4 times more likely to suffer from cerebrovascular complications after the traditional risk factors are controlled for. Hyperglycemia is a significant predictor of fatal and non-fatal stroke and death from stroke. Cardiovascular disease is the leading cause of death. People with diabetes have a 4-fold greater risk. This relates to injury to the vascular endothelium. As a result of peripheral artery disease, diabetic patients are 15 times more likely to undergo an amputation procedure. Once again, hyperglycemia, specifically glycosylated hemoglobin, has been shown to be an independent risk factor for peripheral artery disease. Hyperglycemia inhibits nitric oxide synthase, which impairs the ability of the vascular endothelium to vasodilate. As a result, nitric oxide activated tissue, plasminogen activator, is unable to be produced by the vascular endothelium. Increased production of vasoconstrictor substances such as endothelin-1, which itself has a direct vasoconstrictor effect, is also involved. As a result, we see impaired platelet function, which may lead to increased risk of thrombus formation. And the subsequent hyperinflammatory state causes inflammatory cells to enter damaged endothelial cells and migrate to the intima media where they go on to form foam cells, which is also facilitated by increased levels of adhesion molecules. In the brain, there's an association between hyperglycemia and increased intracellular acidosis, which induces intracellular damage. Also, hyperglycemia is associated with increased levels of glutamate, which may induce neuronal cell death through the activation of glutamate receptors and an influx of excess calcium and mitochondrial injury. Metformin lowers glucose levels by reducing insulin resistance, suppressing hepatic gluconeogenesis, increasing insulin sensitivity, and it enhances peripheral glucose utilization and has beneficial effects on glucose metabolism and lipid metabolism. Its main effect is the reduction of gluconeogenesis, which itself is increased twofold in type 2 diabetes. Decreases fasting glucose levels by 25 to 30%. And whilst the mechanisms are not widely understood, it's suggested the decrease in hepatic glucose production is mostly through a transient inhibition of mitochondrial respiratory train complex 1. In addition, the resulting decrease in hepatic energy status activates AMP-activated protein kinase, a cellular metabolic sensor providing a generally accepted mechanism for metformin action on hepatic gluconeogenic program. Metformin monotherapy has been shown to reduce HbA1c levels by 1.12%. Each 1% reduction in hemoglobin A1c value during treatment of type 2 diabetes was associated with a reduction of 21% in diabetes-related deaths, 14% in the incidence of myocardial infarction, 12% in fatal and non-fatal strokes, and 16% in heart failure. Metformin has been shown to be more effective than other drugs in reducing rates of any diabetes-related endpoint, all-cause mortality and stroke, even though both agents have decreased hemoglobin A1c values equally. It's a first-line oral treatment. It's shown also to decrease abdominal and visceral obesity, possibly attributed to the appetite suppression from metformin. It's associated with a reduction in CVD outcomes, and it's also been shown to limit myocardial ischemia and reperfusion injury independent of any glucose-lowering effect. It's suggested an increase in prevalence of type 2 diabetes is due to reduced physical activity, consumption of unhealthy food, and increase in portion sizes in genetic susceptible individuals. These factors relate to mechanisms we discussed earlier. The AHEAD study included over 5,000 diabetic patients with an experimental group assigned to intensive lifestyle intervention targeting 7% weight loss and over 175 minutes a week of exercise. Mobility-related problems increase with obesity, age, and a lack of physical activity, which leads to a loss of independence and muscle loss, which compromises glucose storage and clearance, as well as compromising quality of life. Each 1% reduction in weight reduced the risk of mobility loss by 7.3%, and each 1% improvement in fitness reduced the risk of disability by 1.4%. Lifestyle interventions demonstrate reductions in fasting plasma glucose, postprandial plasma glucose, HbA1c, and BMI. A one-year lifestyle intervention associated with a 0.7% drop in HbA1c, as well as a 43.6% drop in hsCRP, whereby mechanisms probably relate to changes in autonomic nervous system function. Fitness may improve these factors independent of weight loss through decreasing macrophage pro-inflammatory cytokine production, though adipose tissue itself is also a source of CRP and a major producer of IL-6. 7% weight loss has been associated with 11 millimole to 8.3 millimole reduction after 3.6 months of weight loss. Low-calorie diets have been also associated with a reduction in HbA1c. Effect sizes are larger in those studies that addressed eating as well as exercise habits. Exercise itself increases glycogen synthase, which accelerates non-oxidative glucose disposal as glycogen and activates GLUT4 that facilitates passive diffusion of circulating glucose down a concentration gradient to muscle cells, potentiates insulin signaling by upregulating expression and activity of proteins involved in insulin signal transduction. The release of anti-inflammatory cytokines is thought to play a mechanistic role, offering protection against TNF-induced insulin resistance. These points here indicate the effectiveness and a need for consistency in lifestyle interventions. It's interesting to note that insulin-mediated glucose disposal is improved and insulin sensitivity of both skeletal muscle and adipose tissue improved with or without any change in body composition, possibly through the mechanisms listed on this slide. As we can see, there's many components involved in the development and progression of diabetes, although still quite a lot to learn. Regardless, looking at the drug interventions here that help to lower the risk of macrovascular disease are a great strategy, as well as addressing the risk factors through lifestyle interventions. A final comment here. Lifestyle intervention is at least as effective as pharmacological therapy in preventing or delaying type 2 diabetes. Given the preventable nature of many of the risk factors involved in type 2 diabetes, this raises a question, should drugs be used to treat what is essentially a lifestyle issue? A few references here for your enjoyment. Thank you for listening. Thanks a lot.